an activated vaccine in which vaccine recipients did worse with more hospitalizations, ? And Austin, if there's any clarifying points to that, feel free to unmute yourself to help with that. And that was sent out during the didactic.
Yes, I can probably potentially comment on this extraordinarily complicated issue. Okay, so enhanced immune uptake is mainly most well known in the dengue virus family. Okay, there are 4 different serotypes of dengue virus, and when you're infected with one and then infected with the second one, you can actually get a worse infection, and that's been shown over and over again. And the theory is that it's immune uptake of the virus in an immune cell. Now, we don't, it's speculation at the moment. We have no idea, to be honest, until we do the studies. But the idea would be that this would not be, since there are many different coronaviruses, but there's only one serotype, it seems at the moment, that is actually the cause of major disease presentation. The FDA, in fact, approved just recently the use of antibodies from surviving patients for passive immunity in order to take care of people and try to mop up free virus in patients with severe disease. In other words, you inject antibodies from these patients that have survived coronavirus into patients that are really struggling, and then that hopefully will neutralize or basically prevent the virus from continuing to infect that individual. If immune enhancement was evident, those studies that type of passive immunity would not really be permitted, I would think. Okay, so that's one issue. The other issue is, again, there's not distinct serotypes as of this time. So the vaccine approach is probably still extraordinarily valid approach in prevention. There are some other issues, though. The protein that is a major protein for vaccination that will be used in vaccines is extraordinarily heavily glycosylated, which means that it may not be as simple as some people are suggesting. So we have to do a lot of work yet, and that's when Dr. Fauci and others are trying to caution the idea that at least a year, if not a year and a half, before a vaccine that we can trust and will be developed. I hope so. I hope that answers. I think there's less risk for immune enhancement with this virus, but again, it's dangerous to make that conclusion without the real data.
Thank you, Dr. DeLucia. And our next question is from Melanie. Is it a true assumption that if someone gets the coronavirus and recovers, then they are likely to be immune and therefore less likely to get it again? Or does it depend on if the virus mutates or if there are more strands like the flu?
Yes, I can also potentially answer that. Of course, we have limited knowledge. So the initial results from the Chinese studies have indicated that there's not a reinfection a quick reinfection. Okay, so that's the good news. The uncertainty, though, of whether we can be reinfected by a mutated virus that's slightly different than the virus that's currently circulating, we don't have the answers at this time. But we do know that a reinfection immediately after recovery is not. There's decent data that suggests that's not going to happen. And that also leads up to the idea that a vaccine could, in fact, be a very valid approach.
Thank you again. This question is for Dr. File. Could you please respond to why those who have clinical high suspicion, as opposed to getting random samples with the limited test spas to understand prevalence and incidence?
Well, I'm not sure exactly what they're referring to, but we do have right now a limited capacity of testing. So we have prioritization, and certainly we follow the Ohio Department of Health recommendations of who we test. And basically those are patients that are sick enough to come to the hospital, that have pneumonia, have the characteristics of this, and that's who we're testing. The patients who do not have to come in the hospital because they're not that sick, from what I mentioned before, which is about 80% of the patients, these patients generally, unless they have significant risk factors, are going to do well. It's usually going to be self-limited, and usually within a week they're going to be significantly improved. So because we have the limitations of the test, we're not able, we're not testing those patients right now. Now, in order to define actually the extent of the infection in the community, it would be nice if we could start doing screening of many people within the community. That would help us perhaps define what percentage of these patients have asymptomatic infection. But we're probably not going to know that until we have good antibody tests that allows us to do prevalence studies to look at surveillance within the community. Because this is what was interesting about the SARS infection, is that when the investigators went and looked at people in China who were in, let's say, the Guangdong province, where actually SARS originated from, it appeared that people who were not sick did not tend to develop antibodies, so they probably were never infected with the SARS virus. This is obviously different here with the SARS coronavirus number 2. But right now, because of the limitation of testing, and I'm hopeful that within the next couple of weeks, we'll be able to be much more liberal with our testing. We're going to get much more information about this, and perhaps the percentage of patients who have very minimal infections or are asymptomatic will get a better, clear picture of that segment of the population.
Thank you, Dr. File. And our next question, and I appreciate everybody chatting their questions. I am trying to get to as many as possible, but just so that you know, if we happen to run out of time and if we don't happen to read your question, we are saving all of these questions and we'll be responding afterwards so that we can get everybody answers. The next question is in regards to PPE. Why isn't it a regular surgical mask considered sufficient if there is not a respiratory procedure or otherwise aerosoling activity occurring?
Well, actually, we do consider that a regular surgical mask on a patient is effective. I mean, if you're talking about the patient wearing a surgical mask, if we're not doing a aerosol type of procedure, a surgical mask and a shield over the face is going to be very adequate, along with gowns and gloves.
Thank you. And our next one is any commentary on resource allocation decisions when ICU beds and vents are in short supply?
Well, we're very carefully assessing all of our ICU beds, our ventilator supplies. We're getting additional amount of these from the national stockpile, as well as our pandemic influenza preparedness supply as well. So right now, we're assessing that we can increase our number of patients significantly without having to have a shortage of ventilators or ICU beds. I mean, we're using contingency plans that we're able to convert regular rooms into hospital ICU type of rooms. We'll have enough of ICU physicians that will be able to monitor these. So we're hopeful that we'll be in a good position when we start to see increasing cases come about.
Okay, the next question I have here are, why are patients with lupus being denied their hydroxychloroquine medicine?
Well, that should not happen. I mean, as you may be aware, the Ohio Pharmacy Board issued a rule just last Sunday that pharmacies are prohibited from filling prescriptions for hydroxychloroquine unless there's absolutely a documented test positive for COVID-19 or for the SARS virus, number 2 virus, that they have to have a physician order, that they will only fill a 14-day supply, and there's no refills. So that patients who require hydroxychloroquine because of rheumatoid arthritis or because of lupus should not be denied those medications. And so I think with this restriction, that hopefully will maintain the supply so that those patients who require it for other indications will have that available to them.
Thank you, Dr. Farrell. I have a question. I know we have a number of primary care providers on here, and there's a question from Laura Barr asking, can you comment on recommendations for primary care docs diagnosing over the phone? What they've been hearing is so far to presume diagnosis and act self-isolation for patient and quarantine for the household with a wide variety of symptoms, including atypical ones. Can you provide some guidance?
Yeah, that's true. I mean, we're trying to do a lot of virtual visits right now with, and we have here at SUMA a standard virtual visit screen. And if patients do have respiratory symptoms, like I said before, we almost have to assume that anybody that has respiratory symptoms, that there's a high likelihood it could be due to this. Very interestingly, over the last week, we've essentially seen the incidence of flu dwindle significantly. So we're not seeing the flu like we did even 2 weeks ago, which would confound the issue, because 2 weeks ago we were recommending to primary care physicians, if you had flu-like illness, just treat with the flu over the phone, because that was a high likelihood it was due to flu. Now that's not the case anymore, because we've really seen a reduction in the incidence of influenza. So what we're recommending is to go through a sequence of questions that could define, does this patient have high risk for complications? Are they older, have risk factors, immunocompromised or whatever? If they're not, and they're not having severe shortness of breath or cough or fever, they should be able to be treated just with symptoms at home. We're recommending that you use Tylenol rather than ibuprofen or non-steroidal anti-inflammatory agents, because there's limited data, and I will stress limited, that the NSAIDs may not be good for patients with COVID-19. Also, we're recommending not to use steroids, which sometimes is used in patients with a cough. And excuse me, I've got a cough, just a minute. But at any rate, we're recommending that if they're not all that sick, as the questioner said, just stay at home, self-monitor and quarantine themselves, and usually they're going to get better for 7 days. And if they're afebrile for 3 days, and it's been at least 7 days before their onset of illness, they can come out of quarantine.
Thank you, Dr. File. You ended up answering another one of the questions that had come in. And we're going to go to, has anyone have any recommendations for the crash cart being contaminated during code? Throw away everything or clean and let it sit for a few days. Someone has also mentioned keeping the code cart outside of the room. Could our experts please speak to this?
Well, that's a good question, because certainly we want to maintain efficacy if there is a code called so that there's a cardiac arrest. We want to make sure that that patient receives adequate and appropriate emergency response. And I'm not sure exactly what we're doing right now with that. I'm not sure we've even had that that incidents occur, but certainly we would want to make sure that anything that would have been contaminated would be decontaminated before it's subsequently become available for use.
I might say the stability of the virus in the environment has been studied. There's been one decent study from the NIH that indicates the stability of the virus in various things like cardboard 24 hours, plastic, steel 2 to 3 hours, copper 4 hours, things like that. But I have to also state that these stability studies are taking the virus from that surface and then putting it into a cell culture system that is extraordinarily, exquisitely sensitive to virus replication. So we have no idea, to be honest with you, whether we can extrapolate from those studies to studies of virus in the environment, and then how readily we'd be able to pick it up from the environment. Obviously, we know that we can. So as Dr. File mentioned, extraordinarily importance of hygiene is critical. But it is also, one final point is that the virus can be destroyed effectively with soaps and detergents. Okay, so that's a critical point. So you don't need to be throwing everything away necessarily, but you need to be cleaning things properly and effectively.
I was going to say that at my hospital, we are actually keeping the carts outside the room and passing the meds to the individuals inside the room.
So I have a question that I'm trying to pull together a couple questions from the chat box to direct at Donnie and Jessica. So there's some CDC guidelines, and I guess part of the question is directed at the entire panel, and the other piece is more directed at Donnie and Jessica. But there's some CDC guidelines that are based on, the first question is, are they based on the actual length of viral shedding and the likelihood of passing on the infection? The follow-up to that is, how can we get young people who are not necessarily at the highest risk to take the virus seriously and prevent them from going out, so engaging in the social distancing?
I'm sorry, can you repeat that question for us?
So it was a two-part, and maybe we'll go to the second part first, that how do we get people to take the virus seriously and encourage people to engage in the social distancing and the self-quarantining at home?
Let's see. What do you think? It's hard to say. I think that people will often do what they're going to do. It seems it's hard to convince people to take it seriously. I think at this point, maybe they are. I mean, they're kind of forced to stay inside, but yeah, it's hard to say. I mean, I noticed at our university down here, the day after the universities were shut down, I happened to drive past the downtown area with the bars, and everybody was out celebrating St. Patrick's Day. So, you know, it's just hard to get young people to do that. I'm not sure how. I really don't know how to get them to take it seriously, to be honest. But yeah. Anything?
Right. Like in China, the governments were taking a lot of measures to prevent people to go out and be socialing. And like, I think as far as the US government is doing, I think they're doing great because they're only allowing the essential business, like being able to people. But and also, I think people should have like kind of like a guidance to follow. Like I understand it's hard for people here to have like one standard, or like in China, because most of people will be listening to the government, and like the government will be podcasting like what should the public be doing on the TV. So like all the generations will be listening to them. But here is, I feel like it's kind of hard, but
yeah,
I don't know.
it's hard to get people to do things that you want them to do,
Right.
honestly. But yeah.
I mean,
Thank
like masks is like a good example here because like everyone in China is like wearing masks right now when they're allowed to go out. But here, I don't know. I haven't seen one single person wearing a mask here.
Yeah.
Mhm. And sometimes I wonder, like, if someone starts to wear a mask here, will more people start to do so? I don't know.
Maybe.
Yeah, I don't know.
Yeah, we don't have a great answer for that. Sorry.
Mm.
Well,
But,
thank you. I mean, thank you for, for giving us your thoughts. And I mean, I encourage the other panelists to also jump in with any suggestions on how to get people to take it seriously. And related to the masks, another question that had come up in the chat box was related to masks. Should the guidance be to wear masks if you're not sick? Because that's not what the US guidance has been so far, but what is really the best practice to keep everybody safe?
Well,
And I
Nicole,
also,
may I
So I can wait, Tom, for a second. Just the first part, you can come in on the second part. I would suggest that there's speculation, although it's pretty, maybe, I don't even know if it's valid to talk about, but some of the issues in Italy and Spain are potentially due to the social interactions, the close social interactions that are typical of those cultures. So if we take that as a lesson and perhaps use that and the severity of the situation in those cultures, that we in fact can bring that to home to some of our people here, that it is in fact a necessary component to flattening the curve, as Dr. File has shown us. And I think that's potentially a very important issue that needs to be continually described to individuals, that we will suffer severe consequences if we don't take these things relatively seriously. And I'm sorry, Tom, can you talk about the other point that was raised?
Well, I was just going to comment about the use of masks in people who are well. I mean, the purpose of the masks are to reduce the amount of droplet spread from somebody who's sick. So if you're wearing a mask, it's really for somebody who is sick to reduce the amount that would go out into the 5 to 6 feet from that person. If you're well and wearing a mask, that really doesn't reduce as much of your exposure if you're within 5 to 6 people or a person who somebody is coughing without a mask. So it's much more important to put masks on patients who are potentially sick than the person who is well. And so I just wanted to so address that issue. And then the other issue is, I think there was the question about how long you're shedding the virus or whatever. I mean, we do know from patients who have been followed, particularly in quarantine, that usually, and this is for patients who have not received any of these antiviral agents, that usually it's about 10 days. It can go a little bit longer. There's very rare, I mean, in China, I know that there were some patients that were potentially shedding virus, at least it was detectable. That doesn't mean it was transmissible, but detectable up to about 20 days. But I also want to point out, when I said earlier that for persons who have respiratory symptoms and you're just going to treat them or at least evaluate them by a virtual visit over the phone, these patients were not testing, but we're assuming they could have COVID-19. But if they're not tested and they're not positive, then, and if they're better within 7 days and then 3 days being afebrile, we feel comfortable saying that they can come out of their self-monitoring situation. On the other hand, because I don't want to give mixed messages here, when we send patients home who are positive, we recommend that they be quarantined for 14 days from the onset of their illness, because we know that if they're documented positive and they were sick enough to be in the hospital, they could be shedding for 10 to 14 days. And so there is a little bit of a difference of the duration of the self-monitoring or quarantine based on the fact that we're just empirically recommending that they self-monitor because of symptoms, but they're mild, versus patients who were sick enough to be in the hospital and therefore, and had a positive test, because these patients tend to be shedding more. And that's why there's a little bit of a difference in the duration of recommendation.
I also wanted to speak to kind of that psychosocial component, right, of what we're dealing with our concern for family members and just educating our children about this process. You know, I think it's that hard point. There's a lot of unknown factors that we're still kind of, you know, figuring out as a community of people, and how this is affecting us, and different things change on a daily basis. But I think what's really important is recognize that the concern, I don't know, you know, if they would agree or not, but just I think the concern is more for others' safety, right, than for ourselves, that we could be spreading that virus, and then it's for those that were, you know, who are more vulnerable, that are at that risk. So educating a child about, like, you know, you may feel okay, and but what you may not know is you may be passing something off to someone who is more vulnerable. And so that's what we're doing, is trying to protect them. And that is just one aspect. We don't want to incite fear in our kids, so that then we come out of this in a month and a half and no one wants to talk, you know, and socialize or what have you. So we have to be careful to kind of mitigate that extreme, just taking reasonable precautions, so we don't flip to the other end of things where it could get pretty out of hand, where it would then be detrimental to our mental health if we're being overly cautious.
And Joan, it looks like you've been wanting to say something, so I'd like to give you an opportunity to add to the conversation.
Sure, yeah, so a lot of the panelists covered some of the things I wanted to say. I think from a public health standpoint, it's so important to keep the message often and keep it consistent. So I think one example was Dr. Acton, how she kept bringing out that flattening the curve graph, and she showed it over and over and over again to really drill that point home about how important that is. And so that's something that, you know, I think we all need to just keep bringing that point home. It takes a while sometimes, especially to get through to people who think they aren't at risk. And then also, I think I've been a little bolstered because I think we've seen a big shift over the past 10 to 14 days from spring break and the St. Patrick's Day, where people were really going out, where you're starting to see some of the kids that were saying on spring break that made it in the news and said, oh, if I get it, I get it, it's no big deal. I know one of those kids apologized on social media. So hopefully we're getting through to more and more people, and it's becoming more of a serious situation. And I think people are recognizing that.
Thank you, Joan. And I don't know if you can speak to this question as well. With regards to flattening the curve, where is the US when comparing the current case curve versus the US capacity line?
That I can't speak to our healthcare capacity in the US and where we're at. I know Dr. Acton at the press conference yesterday talked about with their modeling, they feel like the curve is flattening in Ohio at least. I know one thing also that we need to take into account as we flatten the curve is, you know, to look ahead, because I think residents are going to push to lift some of those social distancing actions that we have in effect to keep the curve flat. So we had back in the influenza pandemic in 1918, they looked at data from different cities and their public health interventions. And St. Louis was a city that was very proactive, but as soon as they started to see improvement where the mortality rates went down, they tried to have school go back in session, and they stopped some of the gathering bans, and then they had a secondary spike. So part of it too is these public health interventions that we're doing, the non-pharmaceutical interventions like social distancing, we need to keep those in place. We're not sure how long yet, but for an extensive amount of time past when we start to see improvement.
Thank you, Joan. And one other question, and I see Jessica and Donnie, are you still there? We wanted to say thank you for sharing. And there was a question in there of how is your family doing in China?
Okay, well, I'll let you do that.
Thanks for asking. My family is doing well. Like, no one in my family has had it yet. Well, I believe they are not gonna have it because like they're still the lockdown. Yeah, they're doing great.
Good, thank you very much. There's a question from Patrick. What drug therapy do you recommend for moderate or severe COVID-19 patient presenting to the hospital?
Well, I guess I can answer that. Maybe Dr. Mystery can follow up as well. But, right now, for patients who have mild illness, we're not recommend, it's just all supportive care. We don't recommend specific antivirals. Because remember, we don't have any proven antivirals available right now. A lot of people want to use hydroxychloroquine, but we have to stress that while this drug has been used for decades for other indications and we know about the relative safety of it, it does have some potential significant side effects. I would say probably a third of the patients we wanted to put hydroxychloroquine on, there's relative contraindications, mainly because of heart issues. So we have to be aware of that. So we have sort of a protocol. I mean, a lot of institutions have protocols based on the relative risk factors, age and underlying conditions, the types of severity of the pneumonia based on the oxygenation levels, and then some other laboratory tests which would indicate, are these patients at risk for developing severe complications of their coronavirus infection. Those patients are the ones that were more likely to put on hydroxychloroquine, and we may or may not even add an antibiotic called azithromycin, which at least in very limited and extremely limited studies tends to just suggest there may be some benefit there. And then of course, I think the drug for which I'm most interested in is the one that Angela mentioned, that's a remdesivir, which is a specific antiviral agent, and at least in vitro has been shown to stop viral replication. Randomized clinical trials are ongoing right now. There has been compassionate use in the past, but there's been so much request for that now I think the company has had to stop that. They may be providing expanded access in the future, and so that would be the drug that if we have patients who are fairly sick and in our intensive care unit, as soon as possible, we would like to consider using that drug. But I have to stress that, remember, we still need the clinical trials to show that these drugs are really safe, number one, and effective.
Great, thank you so much, Dr. File. This next question I think is for Dr. Wayne. In light of the problems that we're having in the nursing homes, do you have any suggestions for residential care centers, especially where residents stay and staff rotate in and out?
Yeah, thanks, Emily. It's a good question. I mean, we have talked about some of the data that we're seeing, and obviously knowing that as folks that are older that have multiple comorbidities have worse outcomes. I think earlier someone mentioned that if you look at folks over the age of 70, the mortality rate jumps to 8% and 15% over the age of 80. The preliminary data and this is preliminary, so it's very early to understand the impact in the nursing home. But what it looks like is that if COVID is in the nursing home, there is a risk of infection of about 60% of the nursing home. The initial, and this is data coming out of Seattle, it looks like around half of those would at least be appropriate. Now again, sometimes advanced care plans don't support going to the hospital, but it looks like about half of those infected would ultimately be appropriate for hospitalization. And then the mortality rate in these nursing home residents is upwards of over 30%. So I just mentioned that to understand that folks there are so vulnerable. It's likely the big reason why they're living in a nursing home. So they're kind of a litany of things that we're doing in an attempt to prevent the virus from coming in. We've unfortunately, and this is now national, we're restricting visitation. So from a quality of life standpoint, that's a horrible thing, but there really are no alternatives. So by restricting visitors, obviously that's an extreme social distancing. We're also, and this is pretty typical across the board, but I could certainly talk to what CommuniCare is doing. We screen our staff daily. So for symptoms, we screen with a temperature check when they come into the building. And obviously any symptoms or temp or exposure then we ask that they quarantine at home. We screen our residents on an every shift basis. We're doing temperature checks daily, assessing them clinically on an every shift basis. And I think that actually what we found is that that's actually improved identifying early change of condition. In regards to docs, nurse practitioners visiting the nursing home or even students, I've tried to walk a fine line, and here's the thing. What we don't want to do is make our residents in the nursing home or make our staff in the nursing home feel abandoned. So we have certainly, to the extent that we have docs and nurse practitioners who are committed to coming in, we want to do that in a safe way. So we would screen them in the same way. Obviously, any symptoms, fever, then we would ask them not to come in. We've asked them to try to coordinate or minimize. So what we don't want is each doc or each nurse practitioner going to 3, 4, 5 different facilities. So to the extent that they're in groups, try to coordinate so that one nurse practitioner is in one nursing home, another tries to focus on another nursing home. So limiting the amount of touches, but certainly when appropriate, allowing folks to come in. For right now, it's a fine line. I would actually, I will tell you, I would probably opt for not having students in, only from the standpoint of, again, we want to limit touches, limit the risk of exposure. And the other piece is that we are 100% fully supporting the use of telemedicine. So what a great opportunity with the government loosening some of the regulations around telemedicine and allowing our physicians and nurse practitioners to connect to our teams in the nursing home to support our residents, leveraging telemedicine.
Thank you very much. And as we're getting close to the midpoint of the hour, I want to remind everyone that we will have a survey that we ask that you fill out so that we can get some feedback. There is a link to it in the chat box, and I believe you'll receive it by email. For those on the phone, if you have questions that you've not been able to ask, please send them to neomedecho.edu. And for any questions that we don't get to, we will try to get answers from all of our panelists and then share a full text document of all of the questions and answers. I do want to jump to a question that was asked before we do run out of time. Are there any protocols for other fields that are not necessarily working in the hospital or primary care settings? So mental health, addiction, homeless service providers who are encountering people daily, even potentially even going into homes. Case managers at community mental health agencies might be going into homes. So is there anything that they should be doing to best protect themselves?
I can speak to that. I know that CDC has issued a wide assortment of documents for guidance for different professions. So if you go to the CDC website under the coronavirus section, they'll have a listing, and then you can check and see if your profession is covered under those guidelines. But I know there's numerous guidelines out there for different occupation settings.
Excellent, thank you. Jamie or Emily, do you have another question that's high on your list?
I will ask one more question, and this one was for Dr. File on any idea on how this will affect M4 students who are about to begin residency. New York is now asking / may mandate that M4s to begin working early. Was just wondering what the national discussion and thoughts were on this. And we do have a lot of our students here with us today.
I know this has been under discussion by the graduate education committees and the education committees here at SUMA as to how that is going to proceed. I mean, right now we're excluding residents, and so this is going to be an issue. I mean, I'm hopeful that at least by the time of the next M4 beginning of the year, which would be usually June or July, that the curve would be such that to the point that, it's not going to be an issue to have them avoid coming into the hospital, because it's extremely important for them to get patient education, direct experience for their, for their education. So we're hopeful that by that, within a couple of months, we'll know what we'll be able to do with our residents next year for sure, at least starting in June or July.
Excellent, thank you. probably one of the last few questions, depending on the length of the answers, but how can we make more telehealth services available to those people that don't have the physical hardware or knowledge on how to use that kind of stuff? So the patients that we're all trying to work with, if those patients don't have access to a computer and can't get to the library, are there ideas on how we increase that access?
Well, you know, the CMS has even allowed, or they've waived a lot of their regulations as far as HIPAA rules and, you know, security rules or whatever, to allow us even to just use regular telephones now. And so we've been conducting a lot of our, what I'm going to call virtual visits, and actually they're reimbursing us at a telehealth amount by just using telephones. And as long as we document in our electronic medical records, I mean, the only thing obviously we can't do is a physical exam, but we can certainly go through the other parts of our evaluation as far as, you know, history of present illness and review of systems and evaluation of laboratory tests, et cetera, et cetera. So that is being, because most patients at least would have access to a telephone.
Thank you very much, Dr. File. Thank all of you, really. And I think we might have time for one more question, but again, I want to take the time to thank all of you for joining us today, all of our panelists for answering questions, for putting together the presentation, for every one of you for showing up and contributing your questions and suggestions and many good links. We will pull all of this together. And with this being a very stressful time for everyone, our patients, all of us, students, colleagues, we're going to be offering a second session next Wednesday at noon. So that's April 1st, specifically on dealing with the stress, anxiety, and possible mental health issues that are going on for not only patients, but ourselves. There's a lot of transition in healthcare right now for not only the individual providers, but other team members. So we want to make sure that we have that session also to be able to address, you know, those more specific concerns. So if there is a last question, I'll kind of leave it out there for anyone, and otherwise we can start to wrap up and let Jamie finish with any last minute announcements or things that I might have missed.
No, I think you got it all. There are still quite a few questions. So what I will do is I have saved the chat and we will send that document around for all of our experts to weigh in, and we will distribute that afterwards. And you did cover everything. I did put the link in the chat box for where you can find the link to sign up for next week's session, which is the Project Echo Coping with COVID. So we hope that some of you can join us again for that.
And even though it's been noted in the chat box, we have recorded this session. There was not a patient case, so we will be able to release the entire recording. So we will be able to post the recording, the slides, and then once we have the compiled answers all together, a transcript of the questions and answers for everyone. And for those who weren't able to join us today, those will be available to them online too. Thank you all very, very much.